Start. My name's Ed. I'm one of the final years who, as of last week, has become one of Barts and London's new graduates. It's very nice to be here with you. And I'm going to take you through some of the key important parts of cardiology surrounding reading ECGs, common arrhythmias to identify with them. I'm going to talk a bit about hypertension after that, and then a little bit about peripheral vascular disease. It's typically a surgery topic, so I'll leave it to whoever's going to give you that talk to discuss maybe in a bit more detail. I'll try my best to go over that as well. So just an introduction to these sessions, because this is the first one. So there'll be someone giving the talk on their own independent computer. That stream's going through YouTube, which is controlled by one of the PAL committee. So you can ask any questions on YouTube via the chat, and then whoever's controlling the chat will be able to kind of tell us the question at the end. So hopefully we can answer your questions as we go along. Okay, so let's begin with some of the ECGs then. So first, how do we set up the ECG? So you're going to place 10 leads, 10 physical leads that give you 12 readouts, which is what we know as a 12-lead ECG on the paper. The limb leads are what we see here, and you would place one on each extremity, so you can either go for the shoulders and the groins or the wrists and the ankles. You would go for this color combination, which you can think of as a traffic light combination, starting at the right shoulder: red, yellow, green, and then black in a clockwise fashion, or some people like to say ride your green bike. And then we're going to set up the chest leads, which essentially are encircling the heart to kind of give us a full picture of as much as we can each segment of the heart and what it's doing. So V1 would be in the right fourth intercostal space, parasternally. On the same side, but on the left is V2. You place V4 midclavicularly, and V3 goes between V2 and V4. V5 goes in the anterior axillary line, and then V6 goes in the mid-axillary line, there, in the same intercostal space. And as you will might remember, the angle of Louis is your landmark for the second intercostal space, so you can know that that's 2, count 3, 2, 3, 4, and then trace along there. Okay, so once you've set it up, what you might get at is this nice printout, which is what we class the 12-lead ECG. You'll see you can split it into 3 main sections, and this section here is the section that's giving you the readout from the limb leads, so the coloured ones that we talked about, and that gives you the relationship of each limb lead to each other, and so that's what we see here. On the left side, we see the chest leads that encircled the heart, and from that we can read out different parts of the heart and get a better understanding of what's going on in relation to anatomy. And at the bottom, we have the rhythm strip, which is just the lead 2, which is here, and that's done over for a full 10 seconds, so it's giving us a better opportunity to assess the rhythm and the rate there. And they're organized in a way which I'll talk about a little bit later. So on the ECG itself, you'll see a number of boxes. So each big box, like we see here, is 5 millimeters. and the ECG is set to run at 25 millimeters per second, which means that in 5 millimeters, that is a time of 0.2 seconds. And then each of these big boxes is divided into 25 smaller boxes, each of 1 millimeter in length, and that 1 millimeter small box is equal to 0.04 seconds. So what we really need to remember is that one large square is 0.2 seconds or 200 milliseconds, and one small square is 40 milliseconds. And by remembering this, you'll be able to work out the different lengths with relation to the waves and how long, if something's too long or too short, by knowing the box size in relation to time. So this is a normal ECG. I don't want you to do much with this, just to appreciate generally, again, what we talked about, the rhythm strip. Appreciate that everything looks to be quite regular in rhythm, that we have no real big ups and bumps, anything strange like that. That we can also appreciate that we have what we class as the maybe more easily recognized waveform that we see more often here, with the P wave, QRS, and T wave in a one-to-one fashion all the way along. Okay. So not much, just to appreciate that we need to know what normal is. So I'm going to take you through a common way of reading ECGs and kind of discuss some of the important patterns in terms of rhythms and abnormal findings along the way that we need to pick up. We're going to discuss firstly the rate, how to calculate the rate, the rhythm, appreciating the rhythm, and talking about the axis of the ECG. And then the next part of appraising the ECG is going through the different parts of the waveform itself. So first the P wave, the PR interval, the QRS complex, the ST segment, and the T wave and QT intervals. So let's talk about rate. So rate, a normal rate is between 60 and 100 beats per minute. And we can calculate the rate using the rhythm strip, like I spoke about. And there are two main ways which we can do this. We can firstly know that the rhythm strip is 10 seconds, and then count the number of waves or the QRS complexes we see in those 10 seconds and times by 6. To give you the number of beats per minute. Or you can do a calculation which is the number of big squares between the R waves. So 300 divided by the number of big squares we find. So for this ECG, we can say that when we count them, there's 23 R waves here. That gives you a rate of 138. And I think by eyeballing, you'd say that it's around 2 big squares. So you go for 300 divided by 2, which is 150. And you can see here, the computer's calculated the rate at 138. So I think the first way, counting the number of QRS complex, is more accurate, especially when you have an irregular rhythm. You can't be counting the number of big squares, because an irregular rhythm would mean that distance changes beat to beat. So you can't use the second method. But it's good for maybe getting a general idea about the rate for something that's quite fast. It's not something that you really need to know the exact number for. 150 is not too bad an estimate for that. Okay. So, I wanted to talk to you a bit about what happens when the rate is abnormal. And this is your ALS algorithm, if you've not seen that before. And it tells us basically more than we need to know about, well, pretty much what we need to know about treating abnormal rhythm. So this one's the tachyarrhythmia algorithm. So I'm going to take you through some of the common tachyarrhythmias in relation to how we treat them in the ALS algorithm. So you'll see the beginning step here is your assessment, making sure that the patient is stable in an airway, breathing, circulation, assessing the disability, and then doing a thorough examination of everything. Method, A, B, C, D, E. And after we've stabilized the patient, we need to assess whether this patient is well or unwell. So that's kind of our first decision we need to make. Things that might suggest that they're unwell are that they're shocked, so they're peripherally shut down. They might be feeling faint or have fallen, loss of consciousness. They might have cardiac chest pain or decompensated cardiac failure. So at this point, I think it's good to talk about ventricular arrhythmias, which are most easily classified because they have a wide QRS complex. I'll talk about that a bit more later, but that basically means that the QRS complex is wider than 3 small squares, which is 0.12 seconds. So the first one I want to talk about is ventricular fibrillation. What this is a rapid and irregular electrical activity in the ventricles. It means that the ventricles aren't able to contract in that coordinated way, and it means that there's automatically that loss of cardiac output, any meaningful cardiac output. It is a shockable rhythm, which means it does respond to defibrillation. And we see the classic waveform, something like this, which is a irregular amplitude looking waveform where it's also an irregular rate. It's not doing much, it's just fibrillating with around a baseline there. And if you remember back to our normal ECG, it's far from that. So these patients will be very unwell. They'll likely be completely just unconscious, not without a pulse. So these people need to be given a synchronized DC shock. And then further management would follow, but that would be the immediate treatment of ventricular fibrillation. So that in contrast to a different ventricular tachyarrhythmia, which is a ventricular tachycardia, VT. Here we can get a range of presentations. So they can sometimes be just stable, maybe just having some palpitations, feeling of the chest wall against the heart against the chest wall. And what you get is this regular but wide QRS complex. It's a very fast rate, so going maybe 200, 300 beats a minute here. But it does look like it's quite organized, and it does look like there's maybe something going on there. But these patients can also be unstable. This rate is just too fast to fill the chamber sometimes, so they might be hypotensive. It might be causing too great a demand on the heart, so giving them chest pain and altering their conscious level. We said that these patients may be shocked, may be unwell, so they may require shocking. But sometimes these patients are okay. And then we could this just kind of demonstrates how to follow this algorithm. So they'll have a wide QRS, so it's not below 0.12 seconds, but it is regular. So that places us here. It tells us that it's likely to be VT, and that the treatment would be an initial bolus of amiodarone. let's move on to some of the atrial arrhythmias that are part of this algorithm, which are represented by a narrow QRS, because wide QRSs are generated when the ventricle is having to generate its own QRS complex. So because it's still an atrial dominated rhythm, we get a narrow QRS. So SVT is a supraventricular tachycardia, and that just refers to any arrhythmia coming from above the level of the bundle of His. Commonly, you might get this sudden palpitations, like we said with VT, but in more severe cases, it can cause this type of syncope, falls, loss of consciousness, and difficulty breathing. What we see in contrast to what we saw before is the narrow complex that we spoke about, but also that it's regular. So the RR intervals are constant here, around 2 big squares, but also that we don't see any P waves here. So this is a narrow complex regular rhythm, and so this puts us in the SVT category. The immediate management of an SVT would be to perform vagal maneuvers. So that is something that stimulates the parasympathetics and decreases the sympathetic drive to the heart. So you can do a Valsalva maneuver. So you can ask a patient to blow into a 10 ml syringe really hard. Or if you don't really have one of those, you could just blow against a closed mouth or nose. So that can help in reducing the heart rate. Also, a carotid sinus massage is something that you would go for to try to immediately treat the SVT. If that's not working, you would go for adenosine as a bolus. You can repeat that a few times, and that will hopefully treat the SVT. However, in some cases, it may not. Atrial flutter might be one of those cases, which is a type of SVT, which the ventricular rate may just be unmasked by your treatment of the SVT, which, such as before, we might see something like this, and when you've done your initial management, you may uncover these classical sawtooth pattern flutter waves with a typical atrial rate of around 300 here. So it might be a case that you do have atrial flutter, in which case you would need expert help, and then likely want to just control that rate to begin with a beta blocker. Okay, so that was the rate. Let's talk about the rhythm. And I don't want to speak too much about this. I just want to say you need to ask 2 main questions. Is it a sinus rhythm? So is the sinoatrial node causing a QRS complex in every case? And is it regular or an irregular rhythm? And that means is that the RR intervals are constant between each QRS waveform. Okay, so when we look at this ECG, we see that firstly, we don't see that there are any obvious P waves. I think you could probably convince yourself you might see one, but when it comes to that case, it's best to, it's probably that you're not really seeing anything. And you have an irregular rhythm, so if you take that distance, it's shorter than this distance, which is longer than this distance, so it's an irregular rhythm. Irregular rhythm with no P waves is AF, is definitely the first thing you should be thinking about. So I'm going to talk to you a bit about AF. Atrial fibrillation, or AF, can be classified as acute, which is basically your first onset of AF, or chronic, in which you could subclassify as paroxysmal, which paroxysmal AF is able to self-terminate within 24 hours itself. Persistent AF, which goes on for longer than 24 hours or needs to be cardioverted. Or permanent AF. So this is AF that's resistant to cardioversion and basically something you're just going to maybe leave in that rhythm, not try to change that with any rhythm control method. The treatment of AF, primarily you want to be thinking about the stroke risk reduction. That's the thing that's going to kill your patient, not the rhythm. So we need to think about stroke risk reduction first, and then talk about how to manage the rhythm after that. And with stroke risk reduction, we need to think about the CHADS vascular. This is an important scoring system you need to remember. I'm not going to go through this one by one with you, but we would calculate that for a patient that we're thinking about reducing their stroke risk reduction. And if their score is greater than or equal to 2, we would consider anticoagulation. And what we're going to give is either warfarin or a direct oral anticoagulant. If they're male and their score is 1, we can consider treatment also. The reason we don't do that with females is because females automatically get 1 on the scoring system. And if the score is 0, we're not going to anticoagulate them. And the reason we say consider is because we have to consider whether that treatment regime is obviously appropriate for them. If they have a high-risk patient for bleeding or have something like severe cirrhosis of the liver, you may need to weigh these and have a longer think about whether it's which is more important to anticoagulate or to risk them on a something that could maybe give them even a worse outcome. A tool we can use for that is the HAS-BLED score, which gives us a good idea about what we need to consider with regards to bleed risk. So yeah, calculating a score of greater than or equal to 3, we especially need to think about what's the best for the patient. So we said that the 2 anticoagulation methods we could use are either direct oral anticoagulants or warfarin. So I've put together a little table comparing what may push you to either. Firstly, you want to consider patient choice. So give them the information and what they want to know about it. DOACs, such as apixaban, rivaroxaban, dabigatran, have less drug interactions than warfarin, but still have some important ones we need to know about. But their dosing is more predictable. The onset of action is much quicker, especially compared with warfarin, that initially has this prothrombotic potential as it inhibits protein C and S at the same time. So initially it's prothrombotic, which means we need to give concurrent treatment with a low molecular weight heparin, like tinsoparin, to reduce that risk in the initial stages of treatment, which DOACs don't need. However, DOACs don't have an easily available reversal agent compared to warfarin, which is a vitamin K antagonist, there are very well-defined treatment strategies how to reverse people's INR very quickly, depending on different factors that I'm sure will be covered in your hematology talks. But importantly, DOACs are not licensed in certain situations just because the clinical trials didn't include these patients, so it's not safe to, it's not proven to work in patients with valvular AF, with mechanical heart valves, with hypertrophic obstructive cardiomyopathy, and diseases like sarcoid and amyloidosis. Whereas warfarin's been around for a while, people know how to use it, and it has a wide license. Okay, so after we've talked about dealing with the stroke risk, we need to think about now what we're going to do with the rhythm itself. And there are two main strategies, which is rate and rhythm control. Sadly, there are no easy, complete, comprehensive guidelines on exactly what to do in different situations. There are more just general guidance here. Of course, if the rhythm's causing them any issue, like we spoke about, we would shock them. There are certain instances that you might be pushed towards a more rhythm control method to actually change that rhythm back into sinus, hopefully. And the two cases where you would always try to do this is in mitral stenosis and congenital heart disease, as these patients have very poor outcomes if they're left in that rhythm. So we need to definitely try to act on that in these patients. In paroxysmal AF or new onset persistent AF, we want to try and maybe think about rhythm control. If it's symptomatic, we would need to think about rhythm control. If the rate is just way too high, it should be a rhythm control method that's thought of first, really. And also, younger patients, we would typically try to rhythm control in the first instance as well. That's almost completely the opposite with why you choose rate control. So the patients with rate control may be asymptomatic. They may have had long-standing AF, which makes it more unlikely that it'll revert back to sinus rhythm. So just rate controlling, making sure the heart rate isn't too high, might be the decision we make. And if the heart rate is at an acceptable limit, in contrast to what we spoke about with the rhythm control, it's not going to cause too many problems, we might think rate control is the better option here. So what can we use for rate control? So we could use a beta blocker, such as bisoprolol. Important side effects of beta blockers include fatigue, impotence, and sleep disturbances. And the way this beta blocker works, you'll probably remember, is that it blocks the beta-1 adrenergic fibers, more specifically, and that increases the refractory period of the heart. But because they block the beta receptors, they may have some beta-2 antagonist activity, so we want to avoid these in asthma still. We could use a rate-limiting calcium blocker to limit the rate as well, a non-dihydropyridine calcium blocker such as diltiazem. The common important side effects, are ankle swelling, flushing, and constipation we need to think about. It works by acting on the calcium channels specifically at the heart, which is limits the rate, but also the contractility that we see in the heart, which is why it's avoided in heart failure. Important to note that we can't prescribe rate-limiting calcium blockers with beta blockers due to the risk of severe bradycardia that might follow and asystole. That's a very important interaction that you can't miss. So never prescribe a rate-limiting calcium blocker with a beta blocker. Another option we can consider is digoxin as well. Digoxin has a number of side effects, but we mainly want to be looking at when it's in toxic level because it's a narrow therapeutic index drug. So we may need to monitor levels at times, and we want to check for any signs of toxicity like heart block. It works by inhibiting the activity of the sodium-potassium ATPase on the myocardium, and that, in effect, decreases the rate like we want it to do, but in contrast to a calcium blocker, increases the contractility, and that's why you may prefer that in someone with heart failure that needs rate-limiting medication, because it's able to improve that contractility, and that's just to do with its secondary effect on the calcium channels in the heart by sequestering more calcium in the myocardium, and that allows it to contract more forcefully. However, we do have to be cautious in patients with a low EGFR when prescribing digoxin because of the toxicity issue. Okay, so rhythm control. There are a few different methods we could use. Firstly, the first 3 drug methods that I've kind of tried to give you a bit more detail about. Flecainide is a class 1C antiarrhythmic. It works by blocking sodium channels in the heart, and that decreases the time in the depolarisation phase of the cardiac cycle. However, the caveat is you can only use it in people with normal hearts. So that's the important thing we need to remember with flecainide. Important side effects include difficulty breathing, fever, and visual changes. Sotalol is a non-selective beta blocker. However, is a class 3 antiarrhythmic in its action to control the rhythm in the AF. That works by a potassium blockade, and this blockade of potassium in the cardiac cycle increases the time in which the heart is in the repolarization phase. Another class 3 antiarrhythmic is amiodarone, and we already spoke about that in the use in tachyarrhythmias. It's less preferred because there are a number of side effects. Common ones, important common ones, are interstitial lung disease, so fibrosis of the lung parenchyma, and it causes thyroid issues as well because of its homology to iodine. And as I said, it's the same class as sotalol. So these 3 drugs can be used in rhythm control methods in different regimes. It's quite complicated, so I'm not going to go into that in this lecture, but definitely read up if you're interested. Other ways we can rhythm control, we've talked about shocking, and that is a way we can try and revert people into sinus rhythm. It's probably the most effective way of doing so. We can also ablate the abnormal tissue, which is typically around the pulmonary vein, so you can isolate that with things such as cryotherapy and electrically isolating the abnormal tissue which is causing this discharge and causing the fibrillation in the atria. So that's an option for rhythm control as well, but would never be used in the acute setting. Okay, and because I've just spoke about a few of the different classes of antiarrhythmics, I leave that up for you there. Just to remind you of the cardiac action potentials and and just show you where the different antiarrhythmics work. We spoke about class 1 antiarrhythmics such as flecainide, which work in the sodium blockade, and then with the potassium blockade using amiodarone and sotalol. So when is it safe to cardiovert somebody? When they've been in AF less than 2 days, if they've been anticoagulated for 3 weeks before the cardioversion, and it's possible to continue that anticoagulation for 4 weeks after, or if a transesophageal echocardiogram rules out a thrombus in the left atrial appendage, which is the main place that we're worried about due to the stagnant blood with the non-contractile atria pooling and making a thrombus that might shoot off into the brain and cause a stroke. If we can rule that out, then we can say it's safe to cardiovert somebody. So this is just to tie that all together. I'll mainly leave this for you to read. It's just basically a summary plenary of what we spoke about with AF. When we should shock, maybe more what would push you to a rhythm control method, what would push you to a rate control method, and thinking about the anticoagulation requirements, when to give it and how long for. Okay, fine. This is just because we haven't mentioned the bradyarrhythmias yet, but we spoke about the tachyarrhythmias. So bradyarrhythmias are anything less than 60 beats per minute, people who are really fit and might have a very low resting heart rate. So after our initial assessment, we would say that they're probably at a very low risk of any abnormal or any cardiac risk immediately. So then we would just continue to observe them if we were worried. However, patients may show signs of shock, in which case our treatment of choice would be atropine. And then if we weren't happy with that response, we would consider further atropine pacing through the skin, and a choice of other agents that we could use. Okay, so we've done rate, we've done rhythm, now on to axis. So I'm not going to go into the academics of the cardiac axis. I'm going to go into what we need to know, that I think we need to know anyway, with regard to the cardiac axis and how that relates to ECG. So the normal cardiac axis is minus 30 to 90 degrees. And that is defined by 0 being this horizontal vector, which is made by lead 1, and that's marked by this green section here. And that makes sense because the heart, if you manage to imagine this stuck to somebody's chest, the heart net electrical activity goes in this general direction. So what happens when we have abnormalities in conduction or structure of the heart is the net electrical activity may swing to a different side and may go outside of this normal range that we know of. And that can be defined as either right axis or left axis deviation. So let's say that we have a case where there is right axis deviation. So this is marked by the yellowy type picture here. Causes of which may be something like just being thin, so it can be normal, right ventricular hypertrophy, lateral MI can also cause this right axis deviation. But what we're going to see that matters is that because the electrical activity is going in this direction, we see that lead 3 reads the electrical activity in this same direction. So these arrows are pointing to are showing the leads and the direction in which they read the activity. And so the electrical activity going in the same direction as lead 3 would mean that lead 3 becomes increasingly positive. And however, lead 1, because it's now swung from something in this range where lead 1 would normally be positive, lead 1 might become negative in this range, or does become negative. Okay? And this pretty much the same happens in left axis deviation. So in left axis deviation, the net activity would go towards this red side, and lead 1, which is over here, we can say it might be causing the net activity to read positive in lead 1, but now lead 3, which is normally positive, would be negative because it's the complete opposite direction now to lead 3. Okay, so that's all I'm going to say about that. So now, how do we recognize it? Left axis deviation, like I said, it's swinging the opposite way of lead 3. So what we see is a negative deflection in the QRS complexes in lead 3. And now for the right axis, we see a negative in lead 1 because it's gone over to the right. It's less in the direction of lead 1's vector, so now we're getting a negative deflection in lead 1. And these can be remembered by left is leaving, so lead 1 and lead 3 are pointing away from each other, and right is reaching, so 1 and 3 are pointing towards each other, reaching for each other. Okay, so we've talked about that. Now let's talk about the rest of the, just reading down the wave now. So we're going to start with the P wave. So the P wave represents atrial depolarisation, which is, and it's normal, and it should be less than 3 small squares. The main P wave abnormalities that we will see or are bothered about are when there's right atrial enlargement, and what we see here is that we get a spike or a high tall P wave here, abnormally tall, and that is called P pulmonale. Because it is likely to be caused by a lung disease causing back pressure on the right side of the heart. With left atrial enlargement, what we see is a P mitrale, and we see a little M-shaped P wave. And what that is the left atria enlarging, so now its signal, which is normally hidden behind the right atria because it's closer to the chest leads, is now becoming apparent, and we get the separate signal seen, and that gives us a kind of bifid waveform that looks like an M. Okay, PR interval is measured from the start of the P wave to the start of the QRS complex, and it should be less than 1 large square. It represents the time between the atrial and the ventricular depolarisation, and it can be decreased by the bypass of the normal conduction delay that we see at the level of the atrioventricular node. And this pathway bypass is caused by an accessory pathway, such as in Wolff-Parkinson-White syndrome. The characteristic ECG finding here is this short PR interval with a slurred delta wave that we see here. Okay, so that's when it's decreased. However, when there's an increased interval, this is due to disruption of the conduction pathway, which is heart block. There are 4 types of heart block we need to know. So first degree heart block. I believe you've covered some of these last year, so it should be just a refresher. So I'll try to be a bit quicker here. So what you get in first degree heart block is just a long PR interval. So we can see that from here to here is much longer than a large square. But that this interval remains constant. So that's first degree heart block, a constant prolonged PR interval. Second degree heart block is where we have I think it's not really well marked on this diagram actually. So but what we can see is that the distance between the start of the P wave and the start of the QRS complex is gradually increasing. Ignore these bars, I think. But I think we can appreciate it's gradually getting longer and longer. And then when you see the next P wave without a QRS complex, that is what we see in second degree heart block, this prolonging PR interval, and then this eventual drop in the QRS complex. So that's type 1 secondary heart block. We also have type 2 second-degree heart block, where we have this fixed PR interval. However, it like the second-degree heart block drops a QRS conduction, but we do not see this gradual prolongation. It just drops it. That's the difference between the first and first type 1 and type 2. Okay, and type 3, what we can see here in this diagram is marked the P waves. Now the P waves are quite regular here, but we can see they have no relationship to the QRS complexes. So that's what we see in third degree heart block, that there's no relationship between the P wave and the QRS complex. The treatment of these patients with heart block would be initial ECG monitoring, of course. There may be medications that might be causing this, so we might consider discontinuing these medications, such as digoxin, beta blockers, and non-dihydropyridine calcium blockers. And for Mobitz 2 and third degree heart block, we need a pacemaker. Also, for those that are persistently symptomatic with heart block, we would want to give them a pacemaker as well. Right, and just to give you a diagram about how that works, first degree heart block, that constant prolonged PR interval is a slowed conduction from the atria to the ventricle. So there's some sort of pathway problem there between the two. Mobitz type 1, which is type 1 second degree heart block, is a suppression of the AV node. That's why we get a gradually slower and slower conduction, where it's just at some point it can't conduct and then it resets itself. So it's a suppression of the AV node. Mobitz type 2 is mainly when there is damage to the bundle of His, and it's quite a serious problem. That's why we need to pace it. And type 3 is when we've got complete AV node block, and that's why we have the independent P waves and QRS complexes. Okay. So about the QRS complex, like I spoke about when talking about the tachyarrhythmias, the normal length of the QRS complex should be less than 3 small squares. So when does it become longer? Well, we spoke about the ventricular arrhythmias already, ventricular tachycardia and fibrillation. But bundle branch block can also cause this. And that's when we have a blockade of the bundles carrying the electrical signals either to the left or the right side of the heart. And this is where another mnemonic comes in, when we can use this to recognize the bundle block patterns. So with left bundle block, we can think of William, and the L reminds us that it's a left-sided block, and the W and M, so the first and the last letter, tell us that in V1 we're looking for this W kind of shape, an RS pattern, and then there's this notched R wave that we see in V6. So it looks like an M. That's the opposite to what we see in the right bundle block, where we think about the word marrow. So right bundle block gives you an M shape in lead 1, kind of, and this more difficult to appreciate W shape, I suppose, in V6. So just to give you some examples, this one is a left bundle branch block. So you can kind of see this W shape here, and the M shape for William is better appreciated in V5 than V6, maybe a bit here. And right bundle, marrow. So we can see maybe an M shape here and a W shape here. So I think that helps you pattern recognize, but the more you see of them, the more you can recognize this is generally a left bundle pattern, this is a right bundle pattern. Okay. Also, with the QRS complex, we can talk about hypertrophy. And Hall waves generally mean that there might be some excess muscle, some more electricity going through them. And we can say that we can, on the left side of the heart, you may get a more tall R wave in V5-6. And in the right side of the heart, when that becomes hypertrophied, you might get a tall R wave than you would expect in V1 and 2. Okay, so the ST segment. That's the period when the ventricles are polarized. And we really are bothered about when there's ST elevation. Common causes of ST elevation are, number one, that springs to everyone's mind, is acute myocardial infarction. And that would show a ST elevation in a specific territory of the heart, like we spoke about before. The ECG can be divided into different anatomical areas, looking at different parts of the heart. So that's what we'd see in a STEMI. Acute pericarditis can also cause raised ST segments, but you would see widespread across the ECG, not territorial, and it might be this, it was probably this saddle-shaped appearance, very convex, concave shape. And you can see this also in this benign early depolarization, again, these convex patterns, but more widespread, tend to be a more benign sign. There's no acute management required. Other causes might include coronary artery spasm, such as with cocaine, can cause this, but also other rarer types of angina. ventricular aneurysms, and Brugada syndromes, rare cause. So, what defines ST elevation? Well, that's more than 1 millimeter in the limb leads over 2 contiguous leads, or more than 2 millimeters in the chest leads over 2 contiguous leads. If we want to talk about MIs or STEMIs, a new left bundle branch block is also part of the ECG change that we would define as in keeping with ST elevation myocardial infarction. So that's something you want to look out for in someone you're querying MI. And then just a bit more on the territories of the heart then. So the heart can be split up into the inferior leads, so it's this L shape made by lead 2, 3, AVF. These look at the bottom of the heart, and this is supplied mainly by the right coronary. We can look at the lateral part of the heart, which is 1, AVL, V5, V6. This is the circumflex artery supplies this. And then you get your anterior and septal leads. So septal may be more V1, V2, anterior may be more V2 to V4, but generally just the anterior portion of your heart. And this is mainly supplied by your LAD, your left anterior descending artery. And from this, we should be looking for patterns in ischemia here to identify a myocardial infarction. This is just, this is not a MI talk. I think someone's going to deliver that quite soon to you guys. But just to, something for your reference to look at home. Also that it, how to differentiate between when it's an STEMI, an NSTEMI, and angina. And the fact that you need an important biochemical diagnosis as well as a history. Okay. So this is a anterior lateral STEMI. We can see that here there are ST elevations in the anterior leads and the lateral leads. Importantly also with myocardial infarction is that you would get a nice confirmation that you're there is the right diagnosis is that you get these reciprocal depressions of the ST segment in other leads, which suggests some sort of ischemic pattern happening over there, but it's not a kind of transmural loss of the blood supply. So these are more compounding your diagnosis that you've got this reciprocal change. Here, what we see is a posterior MI. We identified that by wrong way round. I should have put that last, but the ST depressions that we see in the anterior leads, accompanied by a ST elevation. Why that is because the posterior MI is a mirror image of an anterior MI. So you would get actually ST depressions in the anterior leads, and you would get a reciprocal ST elevation, suggesting ischemia coming from the posterior aspect, affecting other regions of the heart. If you were to flip the ECG upside down, it would show an ST elevation, and in leads 1, 2, and 3, and you would see a depression here. Okay, and pericarditis, we spoke about these concave, widespread Saddle-shaped is what they're described as, ST elevations. This was being obviously with your history taking, that you wouldn't just diagnose it straight off the ECG, because there are a number of different causes of this type of potential pattern. But that's what it would look like. Okay, so the T wave now, nearly there, represents a ventricular repolarization. And what we see here are these tall, tented T waves, as they're described. Very tall T waves. And this is what we see with hyperkalemia. Hyperkalemia is defined as potassium of greater than 5.5. Its main causes are potassium-sparing diuretics, so things like spironolactone and ACE inhibitors, and also seen in chronic kidney disease. Its initial management is important to know about, which the renal talks will probably go over, but I'll give you an overview that if it's not so high, if we're talking less than 6, then it might be an option just to monitor them and give them something that binds the calcium and gets rid of it as best as it can without any other more aggressive treatments, calcium resonium. However, if it's less than 6, you want to be thinking about stabilizing the heart with calcium glucuronate, IV. You want to be getting rid of the serum amount of potassium, and we can do that with insulin due to its receptor mechanics, causing intracellular move of potassium from the blood into the intracellular compartment. We give that with glucose to make sure the patient doesn't go into hypoglycemia. Salbutamol can also help in this, but you want to be careful with certain patients that you don't trigger something like an arrhythmia, as it's a beta agonist. That initially corrects the dangerous situation. However, we have to remember that the potassium is still in the patient's body. It's just in a different compartment that we don't measure directly. So we need to remove this potassium in the long term and think about whether we want to do that. If we need to do that by dialysis, or we could give calcium resonium to lower the total body potassium as well. We can't just necessarily correct it and just think, okay, that we don't need to think about the total potassium anymore. We've solved the problem. Okay, and the last little bit then, the QT interval. This bit we don't really need to read. We just we look at what the computer tells us is the corrected, or the QTC on the printout that it gives us. Prolonged if greater than 450 in men, 470 in women. Causes can be congenital. Important drugs to know that cause a prolonged QT interval are antipsychotics, tricyclic antidepressants, those class 3 antiarrhythmics we've already spoke about, and macrolide antibiotics such as clarithromycin and erythromycin. Also, a nice way to remember it are that electrolytes, low levels of certain electrolytes can cause a prolonged QT. Those electrolytes are calcium, potassium, and magnesium. A long QT is important. Oh, actually, so just to show you where to read it, you would read it here. So the corrected QT for this patient was 375, so that's fine. And with the reason we're bothered about prolonged QT is because it can predispose you to going into a polymorphic VT, also known as Torsade de Pointes. And unlike VT, I think you'll remember, which was all the amplitudes were the same. It was a wide complex like this is, but the amplitudes of the waves were quite sharp and quite all of the same height. This we can see this classical oscillating height of the complexes here. And yeah, this is a bad sign. It's a peri-arrest sign. So what we need to do is, if they're shocked, give them a shock. The definitive management would be a bolus of magnesium sulfate to treat these patients, and then obviously treating any underlying cause there might be, such as the drugs. Okay, so I'll give you a bit of a break. We'll have 5 minutes. You can go to the toilet, have a drink, whatever. I'll leave you with this ECG up if you have time to go through it. Okay, so let's start back again. If you had a chance to have a look at this ECG, don't worry if you haven't. I thought about it was that the rate was 78 beats per minute. The rhythm was irregular but sinus. The axis was normal. P waves when present. PR interval normal, QRS normal, ST normal, and T waves and QT interval normal. So an irregular but sinus rhythm mainly, which is sinus arrhythmia. So normal physiology. It's basically just due to the change in the vagal tone with inspiration and expiration, changing the heart rate. As a normal finding, especially in someone who's young and healthy. Okay, so that ends the ECG part. That's the majority of the talk done. Just make sure you practice. PassMed and PassTest have good resources for you to practice reading, and Life in the Fast Lane has really good bank of ECGs that you can draw upon for reference, which I've sourced a lot of these ECGs from actually. Okay, so I'm going to spend a bit of time talking on hypertension. I think there should be a bit of revision, and then some of the more clinically bit, which I'm going to focus on. Just more treatment guidelines that may or may not be familiar to you. So, hypertension is just high blood pressure. It's usually asymptomatic but can cause symptoms for people with end organ damage, which is the main problem we're worried about with long-standing hypertension, sort of why we're keen about treating it. The most cases of hypertension are essential hypertension caused by your genetic background and the environment we live in, such as poor diet, excess salt. But we need to always consider whether the hypertension can be caused by something else. I've listed a number of different causes of hypertension here, but I'm not going to go into every one of them, as they should be covered in other talks as well. But endocrine, renal, and anatomical, such as coarctation of the aorta. And just a bit on the control of blood pressure. So it's controlled by multiple factors. Main ones to highlight are that the amount of sodium and water in the body, which is importantly controlled partially by the RAS system that we'll speak about in a bit. How hard the heart pumps, the rate in which the heart pumps that we spoke about already with agents such as beta blockers that control that, and the systemic vascular resistance, which we can modify, some agents modify that we'll speak about. How do we diagnose it? Well, the patients will come into the clinic, and if they're reading blood pressures of greater than 140/90, we need to be offering them ambulatory blood pressure monitoring or home blood pressure monitoring where they can do it themselves if they've got the facility to do, but they want regular monitoring over different times of the day. If that average blood pressure is below 135/85, they're not hypertensive. If the average blood pressure is over 150/95, we define that as stage 2 hypertension, and we automatically treat all these patients. If it's over 135/85, but under 150/95, that's stage 1 hypertension, and we treat if they're under 80 and have any of these other risk factors. So 10-year cardiovascular risk of greater than 10%. That would be calculated by a algorithm, a Q-risk algorithm that works that out based on patients' demographics. And also things like diabetes, renal disease, cardiovascular disease, and other end organ damage. We would be keen to offer treatment to these patients. The treatment pathway is very well defined. So it uses a number of letters, A, B, C, D. We can think about so A being angiotensin converting enzyme inhibitors and angiotensin 2 receptor blockers. B being beta blockers. We can use C as calcium channel blockers. And D are for thiazide-like diuretics, such as indapamide. Okay, so the initial management would depend on which category this patient fits in. So if the patient is under 55 or diabetic, they would start on a drug. However, if they were over 55 or were of Afro-Caribbean origin, they would start on a calcium channel blocker. Note that diabetes trumps everything, and you would automatically start on an ACE inhibitor because of its renal protective effect. After that, if they were treatment resistant and they're not reaching their blood pressure targets, that we'll talk about in a slide very soon, we'd step them up to next level. So we would either use an A plus a C or an A plus a thiazide-like diuretic. We'd add all three together as the next step if they're not reaching their targets. And then this final step is the more complicated step. We require the serum potassium level for this, and we would give it a drug based on the potassium. So if the potassium is less than 4.5, we would give a low dose of spironolactone, which is an aldosterone receptor antagonist. And that's because spironolactone raises your serum potassium. So if it's too high, greater than 4.5, we wouldn't really want to do that. Instead, we would offer a alpha adrenergic or beta adrenergic blocker. And then after that, refer to a specialist for special other options that they might be able to give. Okay, a bit of that pharmacology quickly. Don't want to bore you too much because it should be a reminder for you. But ACE inhibitors and angiotensin II receptor blockers influence the renin angiotensin aldosterone pathway. ACE inhibitors such as ramipril, lisinopril, angiotensin blockers such as losartan, candesartan. And so renin triggers this pathway by cleaving angiotensinogen when the juxtaglomerular cells of the kidney sense that there's too little perfusion in the way of sodium concentration. Now, this is where the secondary kind of factors that cause hypertension come into play, because things that reduce the total sodium or increase the total sodium or change the balance can influence this system without the blood pressure actually being at fault. So this pathway relies upon another enzyme, angiotensin converting enzyme, to cleave angiotensin 1 to angiotensin 2. This level, the ACE inhibitors block this enzyme activity. And then angiotensin 2 goes on to cause two main effects: vasoconstriction and release of aldosterone from the adrenal medulla, the cortex, and then cause sodium and water retention, which we'll talk about in a bit. But the angiotensin blockers block the effect of this angiotensin 2 at this level, so a level below the ACE inhibitor. Oops. Okay. Common side effects include of the ACE inhibitors dry cough and hyperkalemia, and angiotensin 2 blockers also cause hyperkalemia. Calcium channel blockers are next in our first line therapies, such as amlodipine. They, unlike the non-dihydropyridine blockers, have minimal effect on the cardiac conduction system. And they preference the L-type channel blockers of the arteries, leading to vasodilation, arterial vasodilation, and the subsequent reduction in the afterload and a drop in the blood pressure. Common important side effects include edema, flushing, and erectile dysfunction. Thiazide, like diuretics, work on the distal convoluted tubule, blocking the sodium chloride symporter here. They have a number of electrolyte side effects, including low potassium, high calcium, low sodium. They also have metabolic effects, including hyperglycemia and hypercholesterolemia. Spironolactone is an aldosterone antagonist, like we spoke about. Aldosterone goes to create these sodium channels in the collecting tubule, as well as this sodium-potassium ATPase to facilitate the sodium exchange for potassium at this level. So the reason, the side effects we're really bothered about, like I spoke about earlier, is hyperkalemia. Because of this loss of these receptors, we're not able to get potassium from here to here. So that gives you a hyperkalemia. Aldosterone also gives you gynecomastia, and can cause hyponatremia. Okay, so treatment targets for hypertensive agents. You would aim for 140 over 90, less than 140 over 90 for under 80-year-old. Over 80, we're worried a bit more about falls, so we relax the target to 150 over 90. Diabetes depends on whether you have end organ damage or not. 130 over 90 for no complications, 130 over 80 for end organ damage. Okay, so a few slides on peripheral vascular disease. This is a surgical topic, so I'm not going to really cover it, but it's in the learning objectives of cardio as well. But it should be better covered in your surgery lectures. Peripheral arterial disease is, the major sign is pain when walking, claudication, and I liken that to a limb angina type pain. It's worse on exertion, going up hills because of the extra effort required, and relieved when resting. This little table I put up here, for third years probably don't need to be able to differentiate it with neurogenic claudication, but when you get into fourth year, you'll probably need to be able to tell the difference whether this pain is coming from the back or coming from the blood vessels. So when you have this disease, it's the same as clogged up any arteries, like coronary arteries. It will progress and then can go on to a thing called critical limb ischemia, like a limb MI. Exactly the same kind of progression that you might see in the heart, where you would get rest pain, ulcer formation, gangrene, and that's maybe at something where you get 50 millimeters, less than 50 millimeter mercury at the ankle, blood pressure. And these patients may say they need to hang their foot off the bed at night to relieve it. Investigations, so you do an ankle brachial blood pressure index to look at the ratio there. Between 0.8 and 1 is normal. Less than that, you're thinking that there's something clogging the artery. There's some insufficiency there. You do a duplex ultrasound scan to see the flow in these arteries, and you could go on some more advanced imaging to if you're planning an intervention and need that. The treatment is conservative and medical. So conservative, the first line is exercise programs. These both improve the collateral circulation to that affected limb, as well as help modify the cardiovascular risk factors, as always. Medical management, you can give an antiplatelet agent, aspirin or clopidogrel, and you can give other symptom control that a specialist would give. Okay, so a word on acute limb ischemia. So that is what we spoke about already. And those 6 P's that you learnt come into play here. So pain at rest, severe pain, paresthesia, abnormal sensation, being perishingly cold, pulseless, pale, and not able to move it, paralyzed. Any of these suggest that there is an element of limb ischemia, so we need to treat